as Armin mentioned, we're a bit of a double act today. So I'm going to start with, first of all, a bit of an outline or an overview of the clinical diagnostic challenge that invasive aspergillosis poses. I'm going to look at some of the strengths and limitations of our detection methods. I'm going to focus on three particular biomarker assays and highlight the limitations of these assays, and then look at the possibility of combining the strengths of these assays in a combination testing approach, as we have done at Barts Health in the form of Triad X. And from there, I will hand over to Dr. Agrawal, who will give you further information on the use of Triad X within the Barts Health Trust and the development of our antifungal audit and stewardship tools. So the clinical diagnostic challenge. So incidence of invasive fungal disease has increased dramatically over the last 40 years. This is because of the emergence of patient groups that didn't exist before. Patients receiving stem cell, solid organ, bone marrow transplant, patients receiving treatment for rheumatoid arthritis. These patients are treated with drugs that suppress the immune system and are placed at high risk of invasive fungal disease. So our experience in diagnosing infections in these patients is relatively recent, and optimal diagnostic criteria are often quite controversial. The most extensive research has actually been performed in the hemato-oncology setting, in which invasive aspergillosis is a primary concern. So how do we manage patients? Well, optimal management strategy is heavily dependent on epidemiology and prevalence of these invasive fungal diseases. You have three options for prophylaxis with antifungals. You can go for no prophylaxis, you could go for mold active, or you could go for mold inactive prophylaxis. And after this, we have two broad options of empirical antifungal treatment, where we give an antifungal based on signs and symptoms of disease, but we don't actually have a proven identification of the pathogen. Or we could try and go down a more diagnostic-driven approach and use maybe our biomarker tests to help us to decide whether we use antifungals or not. In reality, the empirical route is the most common route, and this is very largely due to the high morbidity and mortality associated with delayed diagnosis, and due to the absence of adequate diagnostic tools. So I'd like to just have a little overview over non-laboratory options when it comes to trying to diagnose invasive aspergillosis. So we have host factors, as I've already mentioned, underlying disease that places patients at high risk of invasive fungal disease. We have clinical features that we can look for, but these are generally signs and symptoms of the patient being unwell, very non-specific. We also have use of high-resolution CT scanning. This can be incredibly useful. We talk about the halo and the air crescent sign. But in reality, these are not specific to, certainly not invasive aspergillosis, and are not specific to fungal disease. They could be due to another infection, and they could be due to breathing artifact. The halo sign is actually appears very early on and is very transient in appearance, so you need to have exactly the right time of scanning to see it. And the air crescent sign is actually associated with later stage disease and recovery. We have traditional laboratory tests available to us. So the gold standard of diagnosing invasive pulmonary aspergillosis is histological examination or culture from the infected tissue. Now, we very often don't get this because the patients are too sick for a biopsy. We can use microscopy with stains to enhance sensitivity, such as calcifluor white, and you can look for shape and colour and ornamentation of structures, but these can be atypical in the clinical setting. And also, structures need to be quite abundant in order to visualise, so it's not a particularly sensitive method for early diagnosis. And we can also look at culture. Now, ideally, you want culture from a normally sterile infected site, but we don't get biopsies. So you can look at a non-sterile site, but Aspergillus is ubiquitous in the environment, so we have a large contamination problem, which reduces the sensitivity of this method. Moving on to biomarker detection, I'd like to focus on two main areas. Firstly, nucleic acid-based tests, primarily the real-time quantitative PCR. And secondly, I'd like to look at antibody-based diagnostics, focusing on the lateral flow device, which is produced by OLM Diagnostics, and the galactomannan ELISA from Biorad. So real-time qPCR has become a method of choice for detection of pathogen nucleic acids, and for good reason. It has many, many advantages. It's actually very simple to do. It requires only 2 primers, an optional probe, and a single enzyme. It's incredibly high analytical sensitivity. You can, in fact, with an optimized assay, detect a single copy of your target. What this means clinically is debatable, but it is very sensitive. It's capable of very, very high analytical specificity. An optimized assay can detect a single specific target. The assay is also capable of quantifying, and high throughput is possible. But qPCR has limitations. Firstly, the need to purify nucleic acids. Now, there are many, many methods available for purifying DNA from clinical samples. There are many kits available, there are manual methods, and there are many automated platforms. And these bring in variability in the sample type that you handle, the volume that you handle, the chemistry that you use to extract, and the elution volume that you end up with. And this creates a huge amount of variability in the performance of your assay and will massively affect the sensitivity of your real-time PCR. And it's not just the lack of standardization of the extraction that's a problem, it's the massive risk of contamination that comes with the step of extracting nucleic acids. Now, I've put this amplification curve from a qPCR up here as an example of something that people generally don't like to talk about with their real-time PCR assays. So the blue amplification curve is actually from a clinical positive sample for Aspergillus, and the red curves are from our no protein controls. No template controls. So these, in theory, contain only your reagents, but no positive target, no DNA template. But as you can see, they've amplified. They've amplified very late, but they're there. And in reality, a no template control should never amplify. Why did this happen? Well, it can be because Aspergillus is ubiquitous in the environment. It can be that the particular plastics that you're using or the reagents that you're using become contaminated. In reality, it can also be because you performed your PCR loading too close to where cultures are handled and where clinical samples are extracted. And it can even be because you loaded your plate in a room where there was a lot of traffic, the door was swung open several times and lots of people came through. And that on any day can result in contamination. Is this a big deal? It is in terms of especially detection from serum, where you're looking at very low levels of detection. Because when you have a sample that amplifies very late and you have your negative controls amplifying in around the same place, you don't know whether that amplification is real or whether that's in fact contamination. The lack of standardization also applies to the qPCR assay itself. There are different chemistries that you can use. A massive amount of variability is caused by the PCR platform that you actually choose to run your assays on, and the method in which you choose to analyze your assays. And this has resulted in a very wide range of reported sensitivities and specificities in terms of clinical performance for real-time PCR. The European Aspergillus PCR initiative are actually making really positive steps towards standardizing both the extraction and the PCR aspect of Aspergillus real-time PCR. They've actually published guidelines on extracting from serum and whole blood. They're shortly publishing on BAL fluid, and they're also producing recommendations on standardizing real-time PCR itself. Also, we have the emergence of commercial kits, such as the Pathognostics Aspergillosis assay and the RenDX Fungiplex assay from Renishaw. And these again move us towards standardization of our Aspergillus PCR. But only time will tell whether these are actually priced reasonably enough for us to use. And lastly, a limitation of qPCR is that detection of Aspergillus DNA only tells you that the pathogen is present. It doesn't actually tell you anything about whether the fungus is viable and whether it's capable of causing infection. This could perhaps be overcome by using the lateral flow device from OLM Diagnostics. This is an antibody-based detection method, and it uses a mouse monoclonal antibody, JF5, which is specific to an extracellular glycoprotein that's secreted from the actively growing hyphal tip of Aspergillus. So it won't detect quiescent or moribund spores. And it works just like the old Unipeth home pregnancy tests. It's simple, rapid, cheap, portable. It has many advantages and very user-friendly. You add 100 microliters of your clinical sample straight onto the test pad, and now the result is read in 5 minutes. You have a single line that's your internal control and a second line that's positive if Aspergillus is present. Now, the antibody is very specific. It only cross-reacts with very closely related penicillium species, as often occurs in antibody assays, but it doesn't cross-react with Cryptococcus, Candida fusarium, or Rhizopus species. But it has limitations. You're looking at a qualitative result, the presence or absence of a line. You're reading it by eye. You can have a weak, a moderate, or a strong positive, which is always going to be user-dependent. You also have a relative insensitivity when you compare that sort of detection to real-time PCR. A second antibody-based detection method would be the galactomannan ELISA, and I think most people would be familiar with the Platelia ELISA from Bio-Rad. And this is an ELISA that uses a rat monoclonal antibody, EB2A, to detect galactomannan, which is a cell wall polysaccharide of Aspergillus. It's very easy to use. It's CE marked for serum and also for BAL fluid, but it also has its limitations. If you look at the published literature, you find a wide variation in reported sensitivity and specificity in the clinical setting, and this is massively influenced by the study population in which the tests are performed, the cutoff value that's used to assign positivity, and also the definition of a positive result. Is it a single positive, or do you need 2 consecutive positives from consecutive samples? There's also question over the specificity. In reality, the antibody is not as specific as we may like. It's been shown to cross-react in cases of histoplasmosis, cryptococcosis, and it cross-reacts with penicillium and fusarium species. And lastly, there's been question over the reproducibility of the assay. I know it's a horrible slide, but I just wanted to highlight that there have been 8 publications from 2005 that have highlighted concerns over the reproducibility of the galactomannan assay, particularly in serum. And this is when a sample is initially tested and is galactomannan positive, and is repeat tested from the same sample within 24 hours and is negative upon repeat. And you'll see 1, 2, 3 from the bottom, our own paper, we actually published in 2013, also saying that we had seen a significant decline in the galactomannan signal. Interestingly, we didn't see such a decline in BAL fluid samples. Samples were generally stable. We saw the decline in repeat testing serum samples, and often repeat testing within a few hours of the original test result. So this can have implications when there is quite a long delay between sampling and actually testing. Last year, a single publication in JClean Micro boldly claimed that there is in fact no problem with stability or reproducibility in the galactomannan ELISA. However, we shortly after published a letter in the same journal in which we questioned the validity of this paper, as we highlighted that, one, they hadn't referenced most of the papers who had suggested there was signal loss. They included no clinical information whatsoever on the patients that were involved with the sampling. They actually pooled most of their samples. It was a very small data set, and pooling is not advised because you can actually take confounding factors from one patient and introduce them to the pool. And in fact, if you look at their data, it did actually show signal loss post-storage. And indeed, a second letter from a second group, also responding to this publication, also raised their concerns and suggested that they have also seen an instability problem. So I think that there is a growing body of evidence that there is a problem with the reproducibility of the galactomannan ELISA. So in summary, I just want to highlight that no one test is good enough. All of these tests have their strengths, but it's very important to acknowledge their limitations. Perhaps a way of moving forward would be a combination of tests where you can bring together the strengths of these assays. We know that culture is not sensitive enough. We know that histology is rarely obtained until post-mortem, and in reality, less than 15% of the 160 labs in England offer any alternatives. So what can we do? Well, Public Health England have led the implementation of a new combination testing service across Barts Health called Triad-X, a triple invasive aspergillosis diagnostic testing. So we are combining an in-house Aspergillus real-time PCR, which was published in PLOS One and follows the world recommendation MICI guidelines. It also combines it with the lateral flow device from OLM Diagnostics and the Platelia galactomannan ELISA from Bio-Rad. And we test serum samples and bronchoalveolar lavage fluids, and we report results within 2 working days of receipt of the sample. So where does this actually fit into our clinical management algorithm? For that, I shall pass over to my colleague, Dr. Agrawal, to enlighten you. Thank you.